Hello all. What's up everybody? Guys, welcome to our ENT revision session for our upcoming FMGE June. Of course, it is postponed. So July 2025, guys. See, I'm a student as well. I'm also going to write my examination. Um, I'm going to revise my ENT, so I just thought why not let me make a video out of it, guys. I want to say a couple more things, guys. This PDF is properly annotated, okay? No need of any more annotation, nothing. It is properly annotated and updated, okay? Updated. So you don't have to worry about referring other contents. Just stick to this video and I'll guarantee you 15 plus marks, okay? I'll somehow make a way to make this PDF available for you or just comment. The problem is I do not have a common Telegram group, okay? And what is guys, sometimes you may feel like I'm just reading the fact that is because this PDF is properly annotated. And second thing is I do not have the camera to like video record my face. So just hear the audio, have this PDF, and then just simply go through it. This is for people who did not go through ENT. There are some rare people who did not go through ENT. Guys, trust me, this will fetch you 15 plus marks. Look, guys, I'm not here to waste your time or mine. Okay, I promise you that. Then what else I want to say? Just stick to this, guys. Just stick to this. Just have fun, okay? Just have fun. We are actually see, guys. That is just an examination. FMG June 2025 is an examination. Nothing else, guys. Okay, if we fail, shit, bro. Don't give a fucking shit about it, okay? If you pass through, it's okay, fine, bro. Happy and all that. Yeah? Yeah, don't panic yourself, okay? Have fun. Just conquer, okay, guys? Just always have your collars up, okay? Always rich bitch energy only. Yeah? So, guys, let's start. Hope I have said everything. So, yeah. Guys, first of all, here is the journey inside skull from external auditory canal to internal auditory canal. Guys, whenever you think about the ear, always think about the temporal bone. Embryology is very important, guys. Full ear develops from first and second branchial arches. This part is called tragus, develops from first arch, and rest of the pinna develops from second arch. Okay, guys, there is a junction between first and second arch is called incisura terminalis. This part has no cartilage, guys. Touch and say this part is called incisura terminalis, guys. Just above your tragus. Okay, it has got no cartilage. If this union of first and second arch is incomplete, then it will lead to a congenital disease called preauricular sinus. This is preauricular sinus, guys. What is sinus, guys? There will be one opening and there will be a tube-like thing. So, guys, if it is asymptomatic, no treatment. But in case of a recurrent infection, surgical resection of the preauricular sinus tract. This is a real patient, guys. I have seen it. So this is the treatment. You resect the surgical resection of the preauricular sinus tract. Okay, guys. Myself, I have personally seen another guy who is of 28 years old with the preauricular sinus, and he often complains me that his actually it is very disturbing because it is painful. That is because, guys, while bathing, while sweating and all, there is a opening, right? Things will get in, debris will get in, it will infect it. So if it is asymptomatic, guys, don't give a shit about it. But if it is symptomatic, resect it out, okay? Then pinna development completes by 20th week of embryological life, okay? First of all, guys, six elevations form. These are called hillocks of this. These are six elevations, okay? They develop from first and second branchial arches in the head and neck region. Then what happens? The all these six elevations called as hillocks of is fused together to form one pinna, okay? Microtia, guys, small pinna, and anotia, absence of pinna. Normal pinna has two curvatures. One is helix, another one is antihelix. Okay, if antihelix is absent, that condition is called bad tear, guys. What do you do? You do autoplasty or plastic reconstruction surgery for the pinna of the in case bad tear patient comes to you, sir. People are bullying me. I look like rat and all that. So please help me like that. You do autoplasty or plastic reconstruction surgery of the pinna. Guys, the time you should do this surgery is 6 or after 6 years of age. That is because guys, pinna develops only pinna. Guys, here be clear that development of pinna completes by 20th week of embryological life. But pinna gains its maximum size by 6 years of age. Okay, that is why we are doing autoplasty by 6 years of age. Okay, so gaining maximum size and development is different, guys. Be very sure about it. Okay, guys, Darwin's tubercle. This is my fucking year. I have Darwin's tubercle, guys. It is an anatomical variation, conical shaped. It is not a disease. Most commonly present on helix. Tympanic membrane, guys, develops from all the three germ layers: ectoderm, endoderm, mesoderm. Cochlea develops from it is a spiral shaped cavity inside bony labyrinth. Everything, guys, just stick to this video. End of the video, you'll understand each and everything of ear, nose, and throat. Okay, what is needed for FMG? Guys, this cochlea and all will study everything very, very clearly in the upcoming pages. Okay, so don't worry at the start. Cochlea develops from neuroectoderm. Guys, cochlea it is connected to eighth nerve, right? So nerves or neuro connected that way. Cochlea also developed by 20th week of embryological life. See here, guys, cochlea and the pinna developed by 20th week of embryological life. Yeah, mastoid tip it is absent at birth, developed at 2 years of age. Ossicles, there are three ossicles: malleus, incus, stapes. Malleus and incus develop from first arch. Stapes develop from second arch, reach its cartilage. Sizes: malleus is bigger than incus, incus is bigger than stapes. Stapes, of course, that is the smallest bone in the body. Yeah. So guys, just know this. Ossicles and the cochlea, they are already adult size at birth. Parts of ossicle, guys, this is malleus. Malleus is hammer shaped. Head of malleus, lateral process of malleus, handle of malleus, tip of malleus, which is called as umbo. This is anvil, also called as incus, body of incus, short process, long process, lenticular process. Lenticular process is the end of long process. Yeah. This is our hero here, Stapes, guys. Stapes is also called a stirrup, head or superstructure. Oh my god. Now you guys can see clearly, right? I'm really sorry, guys. I did not see that. I'm really sorry. I really sorry. I'm really sorry, guys. Now you can hear, see everything clearly, right? Yeah, sorry, really sorry, I did not maximize it. Okay, guys, this is head or superstructure of stapes. This is anterior, posterior foot plate of stapes. This foot plate of stapes is attached to all window of cochlea, guys. The stapes act like a piston and makes the fluid inside the cochlea move. Eighth nerve is generated. Sound is heard, guys. See this picture, guys. See this gif. Okay, this is the stapes. They act like a piston and makes the fluid inside the cochlea move. See this picture. So that eighth nerve generated and sound is heard. Okay, this stapes is the end of middle ear and start of inner ear. If stapes is fixed, see this picture, guys. See this picture again. If stapes is fixed, that condition is called otosclerosis. Tympanic membrane ossicles, guys, they work as one unit. Okay, and this they conduct sound energy to the inner ear, and inner ear what it does to convert the sound energy to electrical energy so that it can pass through eighth nerve and sound can be heard. They amplify sound energy, guys. This middle ear guy, middle ear transformer ratio, there is something called middle ear transformer ratio. Just know that this also called as amplification factor, AF. The ratio is 22 is to 1. Okay, the ratio is 22 is to 1. The main function of middle ear is impedance matching mechanism. Just keep it in your mind that impedance matching mechanism, there is no time to take impedance matching mechanism. Simple, guys. The sound comes from air medium and then finally gets into liquid medium, right, inside cochlea. So while transferring, there should not be any wastage, right? That is called impedance matching mechanism. Okay, main function of middle layer is impedance matching mechanism. Okay, next pinna. Pinna, it is a yellow elastic cartilage covered by skin. Skin on the lateral surface. Okay, skin on the lateral surface. Um, or on the front side, it is closely attached. Skin on the medial surface or on the back side, it is loosely attached. Okay, Guys, I'm really sorry for the size, okay? I'm really sorry for the size. My iPad is very small and I have a very old iPad. There are a lot of places in my iPad that doesn't sense my writing. So that is why I'm keeping it small, okay? Forgive me for that, guys. Guys, this pinna is supplied by greater auricular nerve, which also supplies the lobular pinna. Patient complains of anesthesia of lobular pinna after parotid gland surgery. That is due to injury to the parotid gland. Guys, just put it in your head. Any tumor below the lobular pinna is called parotid gland tumor. Okay, any tumor below the lobular pinna is parotid gland tumor. Pinna hematoma. Guys, it is a subperitoneal hemorrhage. Guys, this part is called concha. Okay, this part is called concha. Just put it in your head. Guys, what is the cause of hematoma? Of course, trauma treatment is aspiration or drainage plus pressure bandage. Guys, after doing aspiration or drainage, you have to tightly bandage it. Okay, otherwise there will be necrosis of the cartilage leading to post-traumatic deformity of the ear called box's ear or cauliflower's ear. Keloid pinna. Keloid is a type of scar tissue most commonly found on helix. Okay, followed by piercing, guys. Okay, if you pierce in some patients, some people, it will happen. Okay, pinna, guys, any ulcer on the pinna or on nose, it is basal cell carcinoma, rodent ulcer. This is wax, guys. This is wax. Okay, wax in the external auditory canal, guys. Wait, we'll come to that. We'll come to that. External auditory canal, guys, it is lined by skin. Okay, external auditory canal is lined by skin. Middle ear is lined by what? It is lined by mucosa. External auditory canal is lined by skin. There are two parts of external auditory canal. One is cartilaginous part and one is bony part. Just keep it in your head, guys. Cartilage. I love to eat waffle, guys. Waffle cart. Have you ever seen a waffle cart? Okay, waffle cart is very better than Belgium waffle, guys. Trust me, because Belgian waffle I have to pay 200 to 30 rupees, but in waffle cart I just have to pay 100 and they'll give you like loads and loads of cream with that, guy. So cart, why I'm saying that is, guy, cart is always be outside. Okay, cart will be outside. Cartilaginous part is outer part, which is of 8 mm. Inner part is bony part, which is of 16 mm. Okay, bony external auditory canal is made by tympanic part of temporal bone. Guys, just keep it in your head. Consider this as the temporal bone. Okay, temporal bone has two parts. This is Petrus part and this is tympanic part. Whenever you think of inner ear, then always think of Petrus part. Okay, guys. See, wait. See, guys, external ear and the middle ear will always be in tympanic part. Okay, inner ear will always be in Petrus part. Okay, what is that? What is that? Come up with that again. This is Petrus part, always inner ear. This is tympanic part, middle ear and external ear. Do you get it, guys? Okay, mastod is also a part of hair. External arterial canal skin in outer parts has two hair follicles, ceruminous or wax glands. They are modified apocrine glands. Cerumen means nothing but wax. Okay, if wax block the external auditory canal, guys, it will cause conductive hearing loss for 30 decibels. I will never forget this because when I was in third or fourth year, my grandfather took me to an ENT, and what he did was, what a syringing, guys, what a syringing, in what direction? Posterior superior direction. And then he took and then wax will come and flow here, okay? Wax will come and settle here, and after that I could hear clearly. That is when I know I had a like, that is when I know it was actually compromising with the sound. Okay, and then now I realized that, now I am getting to know that it's called conductive hearing loss. That is because wax, what they did was posterior water syringing in posterior superior direction, guys. Very important, they did not use uh, cold water. That is because cold water will stimulate the inner ear and causes vertigo. Okay, only body temperature water should be used. Okay, clear with that, guys? Insect in external auditory canal, guys. Live insect in external auditory canal, first of all kill it using any oil and then remove, guys, because if it is live it may cling on to any part of the area. And when you try to pull it out, it will fucking damage, guys. It will fucking cause damage. Direction of external auditory canal. It is tortuous and others. Tortuous means what? It is not in straight line. What is it? I don't fuck. IDF, which is inward, downward, forward. Okay, next during otoscopy examination, guys, pinna is pulled UOB, upward, outward, backward. Fissure of Santorini, they are natural defect in the cartilaginous part of external auditory canal, guys. See this picture. This is wait. See this picture. This is fissure of Santorini. Through this external auditory canal infection, get into parotid gland. Sensory nerve supply of external auditory canal, very easy. Just stick to it. Consider this box as external auditory canal. Okay. Just mark up AT VV and here this tail is F. Okay. AT in the sense auricular temporal nerve. Okay, so roof on the anterior wall. Then V in the self vagus nerve. So this is here. So auricular branch of vagus nerve, which is also called as Arnold's nerve. Okay, mother, this guy, Arnold's nerve. Okay, what does if you stimulate the nerve? What does it do? It will causes what is this case? Vasovagal syncope and cough. Okay, sensory division. Then guys, posterior superior part. Are you seeing, guys? What is this? This is roof. This is posterior. So posterior superior part is supplied by F. What is that? Sensory division of facial nerve, also called as nerve of Würzburg. Yeah. Diseases of external auditory canal, guys, quite easy. Just know this disease. Diffuse otitis externa, also called as swimmers here. Guys, whenever you doesn't know anything about the topic, try to extract the answer from the topic itself. What is diffuse, guys? Not localization of particular otitis means everybody knows infection of the ear. Externa means outside, guys. So it is you get it right. It is infection of complete skin of external auditory canal. Treatment is topical antibiotic air drop. This is the picture, guys. Localized otitis externa, also called as furunculus, also called as boil. It is staphylococcus staph infection of hair follicles present in the external auditory canal. It is guys here tracheal tenderness positive, which means that pain on pressing this part. What is this part is called? That part is called tragus. Okay, what do you do with the moment glycerin packing? It is anti-inflammatory, reduces pain and edema. Okay, guys, malignant otitis externa. It is also called as necrotizing otitis externa. Last year question, guys. Okay, it is also called as skull-based osteomyelitis. It is a very life-threatening disease, life-threatening infection, and of course, it is not a cancer, guys. It is nothing but infection of underlying bone of external auditory canal. Okay, this disease is seen in elderly diabetics, guys. This disease is seen in elderly diabetics. What is the cause? Cause is pseudomonas. What are the features, guys? Patient complaints of severe earache, guys. More usually at night, okay? Plus blood-stained ear discharge. And facial palsy can also be seen as facial nerve is most commonly involved now. Other than that, 9, 10, 11, 12 nerve is also involved. What is on examination, you will find granulation tissue in the external auditory canal causing blood-stained ear discharge. Treatment is third generation cephalosporins. Automycosis, auto ear mycosis, fungal infection, also called as Singapore ear. It is fungal infection of external auditory canal. Most common fungus is Aspergillus niger. Examination, guys, you will find wet newspaper appearance. Most commonly seen in rainy season. What is the clinical features? Fungus. So obviously, itching will be there. Treatment is oral toileting, which is nothing but, guys, cleaning the ear is called oral toileting. They assholes did not want to understand everything properly, so that is why they are giving everything in complex terms. You have to put it like that. By how you do oral toileting? By suctioning, guys. If you have went to dentist, they will always suck it out using a machine. So suction or dry mopping with a cotton tip rope. What is meant dry mopping? Nothing, guys. Just take a stick like thing here, some cotton will be there. That is called drying. They put it in your external auditory canal. They'll just simply bud it out. That is called dry mopping. Then antifungal ear drops, clotrimazole or statin. Tympanic membrane shows four. Oh my god. Tympanic, this guys, this don't know this condition. Exhaust ear is also called a surface ear. Okay, it is hyperplasia of bony external auditory canal. It is mostly seen in water sports person. Tympanic membrane, guys, it is also called as smearing. Remember, guys, its color is pearly gray. Its color is what? Pearly gray. Okay, what is it color? Pearly gray. Okay, what is it color? Pearly gray. Yeah, it is oval shaped, not round. It is oval shaped. Okay, it is pearly gray oval shaped. Okay, put it in your head. Okay, guys, put it in your head. Okay, surface area is 90 millimeter square. It is set to button size, but effective only 55 millimeter square, guys. See, and also it lies at an angle of 55 degrees with the horizontal. Peripheral part is more mobile than the central part. Okay, it shows movement on cgillization, which is nothing but putting air pressure on tympanic membrane using CGL speculum, guys. Okay, this is the CGL speculum. Tympanic membrane shows four landmarks. Tympanic membrane is semi-transparent, guys. Wait, I'll teach you something. Guys, this thing, you will, any tympanic membrane picture, you will see this cone of light, guys. Okay, what is this cone of light? See, this light, can you see the reflection, guys? This is called as cone of light. Wait, another tympanic membrane. In this tympanic membrane also you are seeing cone of light. Okay, so in this tympanic membrane also you are seeing cone of light. Okay, so cone of light is nothing but reflection from the handle of Malleus, guys. Reflection from the handle of Malleus. This is cone of light. This is tip of Malleus. This is handle of Malleus. This is lateral process of Malleus. Okay. So four landmarks: lateral process of Malleus, handle of Malleus, tip of Malleus, cone of light. Tip of Malleus, also called as Humboldt, is the most reliable landmark. Okay, guys, this is the edge of tympanic membrane called as annulus. Yeah, this cone of light is a reflection of light from handle of Malleus. What is the source of light? It is light of photoscope. Guys, this cone of light, guys, in fifth year, see 5 o'clock position. What is this position? This is 6 o'clock position. This is 5 o'clock. This is 7 o'clock. If the cone of light is in 5 o'clock, then it's right here. The cone of light in 7 o'clock, then it is left here. Come here in find what is this. It is in 7 o'clock position, so it is left here. Okay, so tympanic membrane has two parts. Okay, pars tensa and pars flaccida. This is pars flaccida. Pars tensa, guys, it is lower major stronger part. It is below the level of lateral process of Malleus, guys. It has made of three layers: outer skin, middle fibrous, and inner mucosa. Pars flaccida, also called the sharpness membrane, it is minor upper weaker part of tympanic membrane. It is the above the level of lateral process of Malleus. It has got only two layers, guys. One is inner mucosa, outer skin. Middle fibrous layer is almost apparent, so to speak. Can you see here the lateral process of Malleus? Pars flaccida, pars tensa. It is bigger. It is see, lower major stronger. Pars tensa. This is pars flaccida. Okay. A traumatic perforation of tympanic membrane of any cause, guys. If girlfriend slaps you or you slap your girlfriend, you were using earbuds or any reason, guys, clinical features would be here a conductive hearing loss. Why conductive hearing loss? If the tympanic membrane is intact, then there will be normal vibration passing into the middle ear. But if conductive hearing loss, then the vibration, it won't vibrate properly, so there will be conductive hearing loss and plus or minus mild bleeding. What you do, guys? There is no treatment needed for it. It will patch up by itself. Okay. Yeah, just note, guys, don't put eardrops. Okay, it will make it wet. Don't put eardrops. It is a conservative thing. But in case, if it is painful, just give oral analgesics. E-station tube, also called as auditory tube, pharyngotympanic tube. E-station tube connect the middle ear to the nasopharynx. Everybody knows, right? Please refer to this picture. Okay, this is E-station tube connect the nasopharynx to the middle ear. E-station tube, guys, it is always closed. Okay, with the help of Osman's pad of fact, if only, just give me a minute. E-station tube, guys, it is always closed. Okay, it only opens during swallowing with the help of tensor valli palatine muscle, which the image of that will be following. And guys, patulous, there is a condition called patulous E-station tube, guys. There is a condition called patchless Eustachian tube. Patchless means weakness. Because of weakness, the Eustachian tube is always open, which is a abnormal condition. What is the cause? Which is pregnancy and rapid weight loss. Clinical features would be, guys, you feel the movement of tympanic membrane while you breathe. Also, orthophony, hearing of our own voice. Okay. Guys, this eustachian tube is horizontal at birth and makes 45-degree angle with the horizontal in adults. Length of eustachian tube is 36 millimeter. What is the length of external auditory canal? 24 millimeter. Outer part is bony, inner part is cartilaginous. In external auditory canal, outer part is cartilaginous, inner part is bony. Okay. Here, outer part is 12 mm and inner part is 24 mm. Their outer part is 8 mm and inner part is 16 mm. So they're totally 24, here totally 36. Okay, length. Guys, each station tube opens during swallowing with the help of tensor valid palatine muscle. Main function of each station tube is middle ear ventilation. If the east station tube is blocked, obviously there will be negative pressure in the middle ear, causing retracted tympanic membrane. Retracted tympanic membrane will look dull in appearance, guys. Okay, dull in appearance. Too much of retraction will cause retraction pocket formation, guys. This retraction pocket is lined by skin and filled with keratin. This is the mother of cholesteatoma, guys. It is a condition we'll study in the further pages. Okay, most common site of retraction pocket is pars flaccida, guys, because it is the weakest layer, right? The retraction pocket is lined by skin and filled with keratin, and keratin is nothing but dead skin. See, guys, if the retraction pocket is allowed to progress, it will rupture, and there will be perforation at the tip of fundus of the retraction pocket, leading to skin growth in the middle ear. Guys, middle ear it is lined by mucosa. So skin in middle ear, it is ectopic condition called cholesteatoma. Cholesteatoma will be pearly white in color. Okay, normal tympanic membrane, how it will be, guys? It is pearly gray in color. Cholesteatoma, pearly white in color. Yeah, glue ear, it is also called as serous otitis media diffusion, the secretary otis media. I don't know who the hell in this world are naming these things so much, guys. Already we have some loads and loads of stuff to study, and these motherfuckers are naming a simple one thing 4 5 times assholes. Shit. This is the most common cause of hearing loss in children. Okay. It is nothing but, guys, collection of sterile glue-like fluid in the middle layer. Guys, here something that you should know, it is sterile. It is serious. It is not a pus. Okay, it is not infect. It is non-infectious. Okay, you get it. It is non-infectious, guys. What is the reason? Reason is eustachian tube blockage. It can occur due to two reasons. Okay, adenoid hypertrophy, nasopharyngeal carcinoma. Guys, adenoid hypertrophy, of course, in only in children you will find adenoid. You know, right, guys? Only in children you will find adenoid. Okay, see this picture. Okay, adenoid hypertrophy is seen in school-age children. This causes bilateral eustachian tube blockages, causing bilateral glue here. This is the most common cause. Nasopharyngeal carcinoma, usually seen in elderly adults. This causes unilateral eustachian tube blockages. This causes unilateral glue here, and it is a rare cause. Okay, guys. Clinical features, guys. Clinical features, just a close relation. Listen to me, guys. See, a poor performing school age children due to conductive hearing loss, on further asking complaints of heaviness in the ear, but it is not painful. Do you get it, guys? I'll just summarize to this part. Okay, I'll just summarize to this part. Guys, on examination, you will find glue-like fluid behind the tympanic membrane, air bubbles trapped inside the glue, no pus. It is a chronic disease, sometimes with adenoid phase. Guys, this is adenoid phase, that is open mouth. Okay. And guys, treatment is surgery. What do you do? Myringotomy in anterior inferior quadrant. Okay. Hey, what is this, guys? Grok. Everybody knows Grok because nowadays everybody uses this Twitter thing called as X for what everybody knows. So what is this, guys? AI. Okay. So I am telling you this. AI is anterior inferior quadrant. Okay. Uh, For what, guys? For grommet insertion. This is called grommet, guys. For what? Air will grow into the middle ear. So middle ear ventilation. Okay, plus or minus adenoidectomy if it is needed for adenoid. Yeah. So guys, middle ear it is also called as tympanum. Okay, middle ear produces mucus that drain into eustachian film. What is the main function of middle ear? It is sorry, what is the main function of middle ear? It is impedance matching mechanism. What is the main function of eustachian tube? Middle ear ventilation, right? Yeah. Next, middle ear is a hollow cavity in the tympanic part of temporal, guys. I have already taught you whenever you think about external ear, middle ear, always correlated with tympanic part of temporal bone. There are three parts, guys: epitympanum, mesotympanum, hypotympanum. Epitympanum, it is the upper part and also it is the deepest part. It is also called as attic. It is covered by a bone called scrotum. Mesotympanum, guys, it is the largest part. It is covered by tympanic membrane present in the middle ear. Hypotympanum, it is the lowest part of middle ear. It is covered by a bone which is unnamed, guys. Okay. Next, the depth of middle ear, epitympanum 6 to 4. Just mug up 6 to 4. Epitympanum, mesotympanum, hypotympanum. Sensory supply of middle ear is by tympanic branch of glossopharyngeal nerve, okay, which is also called as Jacob's nerve. Everybody know this guy Jacob from that wolf, this wolf guy. Oh shit, this is Twilight Saga. Yeah, I forgot it, guys. I have seen it like before 5 6 years something. Yeah. Next, guys, this Jacobson nerve will cause otalgia, that is ear pain. Okay, after tonsillectomy, tonsillitis, myalgia. Vagus nerve, V10, RLN, SLN are nerves now causing earache after cancer supraglottic, cancer pyriform sinus. Six walls of middle ear, guys. Who is she? This is nothing but Aishwarya Rai. Yeah. Oh my God. This is everybody knows that. Wife of Ranveer Kapoor. Okay, Ranveer Singh. Sorry, guys. I'm very bad at Bollywood, guys. Guys, this is Deepika Padukone. This is very simple annotation, guys. Don't middle ear, guys. Six walls of middle ear, guys. Focus on this box, okay? This is roof. Above the roof lies door of temporal lobe. Below the floor lies what is this, guys? Bulb. What bulb? Jugular bulb. Anterior wall has two openings. One is for tensor tympani muscle, which is attached to malleus, supplied by mandibular branch of trigeminal nerve. This opening is for ET, eustachian tube. Posterior wall has a structure called pyramid to which stapedius muscle tendon is attached, supplied by seventh nerve, facial nerve. In case has got no muscle attachment, guys. Guys, everything what I taught you will be here. Other than that, no. The sigmoid sinus is just behind the ear. Okay. Yes. All this thing I have already taught you. Like refer to that picture above. Okay. Lateral wall is, guys, tympanic membrane made by tympanic membrane. Medial wall, behind the medial wall lies inner ear. Medial wall has great two projection. Okay. Do not forget this. Medial wall has got two projections. Okay. One is promontory, which is nothing but projection of basal turn of cochlea. Okay, then another thing is lateral semicircular canal bulge. Okay, LSC. I have made this Kim Kardashian picture, that is because I was keep forgetting. Okay, remember, guys, there will be two projections uh, in the medial wall. Okay, medial wall of middle ear. One is lateral semicircular canal bulge, another is promontory, which is bulge of base projection of basal turn of cochlea. Yeah. Next, guys, medial wall also has two windows. One is oval window. It is covered by foot plate of stapes. Round window. It is covered by round window membrane, also called the cylindric tympanic membrane. Guys, myelinitis bullosa, viral infection of tympanic membrane, clinical features earache. You will find vesicles on the tympanic membrane. It is self-limiting disease. Just give oral analgesics because of earache. Okay, guys, just telling you a trick. Earache always connected with analgesics, oral analgesics. Okay, did we miss anything here in this page? Just know this, guys. Middle ear, okay? This part is called middle ear, right? What could be the source of infection? Eustachian tube. See, through eustachian tube, this part is called nasopharynx, right? So nasopharynx will be the source of infection for middle ear. So otitis media, nasopharynx. What is this guy? This is eustachian tube. Middle ear, from the middle ear, the infection may go to mastoiditis, or to petrous apex, petrositis. Just know them, okay? Next, three diseases that we're going to study, guys. Put it in your damn fucking head. Eosom TTAA. Eosom TTAA. Eosom TTAA. Okay, acute suppurative otitis media, tensor tubotympanic eosom, aticontral eosom. Okay, don't worry, guys, we'll study clearly. Are you guys seeing here? My iPad is like, what do you say? It is quite slow. Mm-hmm. No. So guys, shall we take a minute rest, please? I want to take my tablets. My health is not good, guys. Just give me a minute. My health is there is since of course, like I there is nothing bad in what to say. Nothing bad in if I'm not sharing with you guys, I'm actually fighting depression. I can't say fighting, I'm almost fought it out for like one like from 2020 I was in depression, guys. 2024, that's just last year I went to psychiatrist, and somehow one final psychiatrist made my he prescribed sertraline properly, guys, with proper. Then I'm right now I'm very much pretty much okay. That is because my depression, honestly, guys, 2020 I had breakup. Okay, because of that breakup, and my family is, guys, I'm very, see, guys, I am the most luckiest person, most happiest person in the world. That one I cannot deny. But what to say, see, if I need help, I don't know it is because of God, or I don't know it is because of the way I'm born. I'll always have help. I'll always have people supporting me. I'll always, what to say, guys, uh, favorite child, okay? This universe favorite child, that I cannot deny that. That doesn't mean that it did not give me any problems or crying. No, universe fucks me each and every time it is. But then, yeah, I was because I had a breakup. I was crying for like almost, you won't believe, guys. Till end of 2021, I was crying. For me, breakup I started crying. Exactly remember the date, June 2020, Jan 17, 18, some 20, like third week of Jan, I started crying, guys. Then continuously I cried for 2 whole years. Can you believe it, guys? And I can say like I'm 90% out of my breakup now. Sometimes it may feel absurd, or is too much, but guys, I do not know. That is what has happened. I did not want this to happen for myself. Do I want to cry? No, right? Also, guys, I do not have the habit of smoking or anything else, okay? Even I don't do drinking. But porn, of course. Guys, here I live with my grandmother and uh, myself, okay? Like, so it is like grandmother will be in hall and I'll be in my own room. You know what happens, right? So it is like that. I was in a dark area. There will be no, of course, no fucking light comes into my room, guys. I have TV, Wi-Fi, all these Netflix, Disney Hotstar thing will be going on. I don't know, guys. Because of that, I won't say I wasted a lot of years, but I couldn't do anything, guys. Honestly, I was suffering a lot. I had panic disorder. Even now, I have panic disorder, but there was a time, I used to rush to the hospital. I used to rush to the hospital, guys. Being a doctor, not doctorate, of course, I have to complete FMGE, but what to say, like after completing MBBS, you are rushing to the hospital thinking that you are having heart attack. Guys, panic disorder makes you to think that you have heart attack. At least for me, okay, this panic disorder messes with your mind, guys. Okay, panic disorder, guys. I'm telling you this that is a rush of some. Uh, that is due to imbalance in your brain chemistry, and that will cause I think rush of adrenaline, and you'll feel intense dooming pain. Okay, remember this word, dooming pain. This is psychiatry. So dooming pain, there'll be a lot of palpitation. You'll be, and guys, you won't believe it, guys, even I cannot believe it. I started having phobias, guys. I started seeing, like, right, I was on proper, I needed proper psychiatric support, guys. Finally, after visiting one, two, three psychiatrists, then on I finally landed up in the hands of Maridavanand sir, who is the assistant professor of psychiatry in a government college, Namakkal government college. And then because of him, I'm here, guys. Honestly, there was a time I what to say, I lost I lost hope in my life. I thought I'm gonna die. Honestly, guys, I thought I'm gonna end my life. And I had like I decided, guys. I decided. I know. I don't know what happened to my fucking brain. I decided. Then on, I went to Madhavanand sir, psychiatrist, and then on he prescribed me. He after like the first session, he asked me, so like, do you have trust? I said, do you trust yourself to come out of this? I said, no, sir. Guys, right now I'm talking maybe clearly to you how I'm explaining, but then that time, believe me, guys, I was not even fucking in my, not even what to say, living in reality. I was like in my own world. I do not know what is happening. So much of fear inside me, like that. He asked me, do you trust your recovery? I said, no, sir, but I trust in you, like that. And he said, okay, we'll sort it out, no problem. And I came home. He put me under 25 mg of sertraline first, and then he took it to 50 mg, then a little bit more increased. He prescribed what is that? Oh, fucking, I forgot it. What is this, guys, that they prescribed first? Not alprazolam. It was what? It was. I don't remember it. Oh God, shit. And then, guys, right now I'm pretty much okay. Right now I'm taking 75 mg sertraline a day. Morning I used to take 50 mg, and night I used to take 25 mg. And along with that, you won't believe me, guys, I'm taking metoprolol. That is because of, guys, I am having a lot of anxiety and my blood pressure is. You won't believe me. I have seen my blood pressure at 180 systole. I don't remember the diastole, but systole was 180. Not once, guys, for a lot of times. Even day before yesterday. Guys, sorry for wasting your time, okay? Really sorry for wasting your time, but you have to listen to me. You guys have no other. Done, guys. I took my tablets. Metoprolol is 25 mg. So, yeah, guys, middle ear cleft, it is collection of all hollow spaces in the temporal bone. Okay, just have this. This is middle ear. This is antrum. Antrum is the largest and the constant mastoid. So it is connected to middle ear via adductus, then eustachian tube, a rest of mastoid accents. They are all mucosal and they are all interconnected. Guys, infection of middle ear cleft, acute suppurative otitis media. It is infection of, guys. Before that, just know one thing: Petrus part, tympanic part. Yeah, this is internal auditory canal. Always, guys, whenever you think about internal auditory canal, correlate with eighth and seventh nerve. Okay, facial nerve and vestibulocochlear nerve. And then this Petrus part, there will be fifth nerve and sixth nerve, guys. Okay, abducens nerve and trigeminal nerve. Trigeminal nerve and abducens nerve. Okay, that's something I want to say. Infection of middle ear cleft, acute suppurative otitis media, infection of middle ear mucosa by pyogenic organisms, Streptococcus pneumoniae. Infection, I have already told you, goes from nasopharynx to middle ear via eustachian tube. Clinical feature is earache, usually after upper respiratory tract infection. On examination, guys, you will see red tympanic membrane with a dilated capillary showing cast wheel sign. Then treatment is medical management. Patients of ASO with red bulging tympanic membrane, you do myringotomy in posterior inferior quadrant. For glue ear, you do myringotomy in anterior inferior quadrant. Guys, if it no treatment is see, guys, if this thing in ASO with the red bulging patient, myringotomy is not done, there will be perforation. Okay, if it is no treatment taken for 3 months, then there will be permanent perforation. Okay, where in the pars tensa part of tympanic membrane. This is called safe CSO. It is also called as tubotympanic CSO. Okay, permanent central perforation at the pars tensa, which is the strongest, lower major stronger. Yeah, clinical feature is ear discharge, but here it is not foul smelling, not blood stain, plus conductive hearing loss. There can be ossicle erosion also. In disease can eat away ossicles. Most common in the first ossicle to be eroded is incus, guys, as it has got no muscle attachment and least blood supply. Okay, treatment is, guys, surgery. What you do here? Tympanic membrane is gone, so you have to repair the tympanic membrane. What is that called? Myringoplasty. Here you use a graft, which is temporalis fascia graft. Here, whilst post-oral incision is done, here Mollison self-retaining mastoid retractor is used to expose the ear. It is a microscopic ear surgery. Here, guys, for ossicular erosion, you know, type 3 tympanoplasty or columnar tympanoplasty. Then there is erosion of both the malleus and incus, guys. Only stapes is present. What you do? You keep the graft in such a way that it is in contact with the stapes so that the continuation of sound transmission is restored. This surgery is called myringostapedopexy. If ASOM, complication of ASOM and CSOM, guys, acute mastoiditis, infection of mastoid as well, guys, here you will never see headache or fever. Okay, clinical feature, people will come to complaining, sir, I have pain behind pinna. On seeing, you will see red smooth shiny skin over mustard, which is called ironing of mustard, which is the first sign of mastoiditis. Next, guys, mastoid tenderness positive. Okay, when you touch, there will be pain. Okay, and not just edging, usually it will be. Okay. Next, patient has very important, guys, profuse, okay, profuse ear discharge, okay, which means a lot of like it is flowing like hell. Reservoir sign, it is seen in acute mastoiditis. What is reservoir, guys? Reservoir in the sense, see, there will be a lot of pus inside, guys. Okay, how much ever you clear it out, how much ever you wipe it out, it will keep flowing. Then lighthouse sign. What is lighthouse sign? When you use an otoscope and use a light to see it, you can see the flow of pus and the movement of light. Okay, that is called lighthouse sign. Here lighter should be there. I do not know. That's okay. X-ray investigation, guys. X-ray mastered, Schuler's views and Townie's view. Most common is Schuler's view. Treatment is cortical mastectomy, also called a Schwartz operation to clean all the mastoid add cells. First step of any mastoid surgery is guys to find the antrum. Okay. What is the surgical landmark for finding the antrum? It is McEwen's triangle or suprameatal triangle. Corner septum, it is seen in some people during mastoid surgery. It is anatomical variation of mastoid. It is remnant of petrosquamous suture. It is difficulty. It lead to difficulty in finding the antrum during mastoid surgery. Guys, this lighthouse seen in acute mastoiditis, also in ASOM in some stages of separation. Okay, lighthouse scene. Okay, see this lighthouse. Yeah. Next case, if the mastoiditis is not treated, it will lead to abscess formation. Most common site is posterior auricular mastoid abscess. If the pus comes along the sternocleidomastoid muscle, bizoid abscess. Along the digastric muscle, Sittelis abscess. Pitrositis is also called as Gredinigo syndrome. It is infection of Pitrus apex air cell. It has got three features, guys. Just imagine GERD, Gredinigo syndrome. Ear discharge, retroorbital pain, diplopia. Ear discharge, retroorbital pain due to fifth nerve. Diplopia due to sixth nerve involvement. CT scan will show abscess over Petrosic. Treatment is surgical exploration. Then see this one is, guys, along the sternocleidomastoid muscle, bizoid abscess. Okay, this is posterior auricular mastoid abscess. Where is the digastric metacytilic abscess? That picture is not given in the workbook itself. So what can I do? So guys, very important disease. Unsafe CSOM. It is also called as atticoantral CSOM. Attic, guys. Do you remember, guys? Epitympanium is also called as attic, covered by a bony scrotum. So connect it like that. So atticoantral CSOM. Okay, the presence of cholesteatoma is the hallmark of this disease, guys. Okay, it is pearly white in appearance. Normal tympanic membrane will be pearly white in appearance. This is called, guys, primary acquired cholesteatoma. It is the most common type. Okay, what is the cause? The origin is due to retraction pocket. What is the most common site of cholesteatoma? It is Prusak space of epitympanum. It is nothing but the space between neck of what is this, guys? Neck of malleus and the pars flaccida. Okay, this is unsafe because of bone erosion caused by cholesteatoma. How does the bone get eroded? Because of inflammatory osteitis, and it secretes bone destruction enzymes leading to bone erosion. Okay, here, guys, bone erosion means temporal bone erosion. Imagine if your temporal bone get eroded. So eye problem. Clinical features: ear discharge with chronic foul smelling air discharge with conductive hearing loss, guys. Somehow put this line in your mind, brain. Okay, what is that? Chronic foul smelling air discharge with conductive hearing loss. Okay, Again, chronic foul smelling ear discharge with conductive hearing loss. In CSOM safe, you will see ear discharge, but it is not foul smelling, not blood stain, but it is unsafe CSOM. What you will see chronic foul smelling ear discharge with conductive hearing loss. Okay. Next, guys, treatment is modified radical mastectomy, also called as tympanomastoid exploration. Main aim of MRM is to make the ear safe. Complication of unsafe ear, there are five complications. Most common complication is mastoiditis. Most common intracranial complication is meningitis. Most common site of autogenic brain abscess is temporal lobe. Guys, anything related to brain, guys, abscess kind of, then you can connect it with headache, vomiting, convulsions, and here specifically what I told you, chronic foul smelling ear discharge with conductive hearing loss. Can you see this picture, guys? This is autogenic brain abscess, mostly seen in temporal lobe. Okay, investigation is CT, treatment is neurosurgery. Labyrinthine fistula, which is nothing but inner ear erosion. It is erosion of bony cover of lateral semicircular canal bulge which lies on the medial wall of middle ear. Clinical feature is, guys, vertigo in a patient of chronic foul smelling ear discharge. Examination shows positive fistula site, which is putting air pressure on the tympanic membrane. Patient show nystagmus and vertigo. In normal patient on serialization, fucking nothing happens, guys. Next, false positive. False positive in the sense. It is wrong. It is false positive. There is no fistula, but the result says that the fistula is there. That is seen in that is seen in congenital syphilis. That is because sensitive inner ear guy. This is called Hennebert sign. False negative fistula sign, which means see, the result shows the fistula is absent, but then in reality fistula is present. Okay, so which will be seen due to if the fistula is in dead labyrinth or fistula is covered by cholesteatoma. Okay, sigmoid sinus thrombosis or lateral sinus thrombosis. It is also an intracranial complication of unsafe CSO. Guys, here you will see headache, spiky fever, or picket fence fever, pitting edema on mastoid. It is Greisenger's sign. Here, no change in CSF pressure on pressing internal jugular vein. In normal people, pressing internal jugular vein, infused CSF in rise. CSF pressure can be checked in two ways. One is Tobe air test, that is through lumbar puncture. Croway Beck's test, that is to fundus examination. CT brain will show delta sign. Treatment is MRM plus clear the thrombus. Here comes the inner ear, which is also called as labyrinth, guys. Okay, it has got two parts: membranous labyrinth, bony labyrinth. Membranous labyrinth is actually inner ear. Bony labyrinth, it is the cover of membranous labyrinth. It is formed by pittress part of temporal bone. It is the hardest bone of our body. Next, there are three parts: cochlea, utricle sacal, semicircular canal. Has got sensory end organ or receptor, organ of cortei for hearing. Utricle sacal has got macula for linear balance, seminals. There will be two maculas, one in each cochlea. Okay. Guys, crista, it is for angular balance, aka equilibrium. Okay. This thing will steady again clearly. My iPad is like about to burst, See, charging will resume and the iPad returns to normal temperature. So guys, cochlea. Before that, we'll complete fluids of inner ear. Guys, inner ear is filled with endolum and produced by stria vascularis of cochlea. It is absorbed by endolymphatic sac. If the sac does not absorb, then it will lead to a disease called Meniere's. We'll study everything clearly in the coming pages. Guys, this endolymph has high potassium and low sodium. Okay, perilymph surrounds the inner ear and it has got high sodium and low potassium. Perilymph is nothing but CSF in subarachnoid space. This is the cause of post meningitis deafness. Okay, after meningitis, people have deafness. That is because they are connected through a channel called aqueduct of cochlea. Next, guys, cochlea. It is what to say. Cochlea. First point is two, three by four turns. This part is called apex. This part is called basal turn of cochlea. Basal turn of cochlea is towards the oval window. The apex is for low frequency. Basal turn is for high frequency. Apex is also called as helicotremma. Each part of the cochlea is responsible for each sound. Central axis of cochlea is called modulus, along with which the cochlear turns form. This called spiral ganglion of eighth nerve. Saccule is connected to cochlea through ductus reunions. Function of cochlea is hearing. Organ of cortei is the sensory end organ. Has got two cells, outer hair cells, inner hair cells. Outer hair cells mostly affected by noise-induced hearing loss. Okay, this part is very important, guys. Okay, not this part, this part. Okay. Next, cut section of cochlea, guys, just put it in your head. VMT, scala vestibular, scala media, scala tympani. Okay, scala media is the actual cochlea. This layer is called rhinous membrane. This is basilar membrane. This is tectorial membrane. This is organ of cortei. See, sound comes and it will stimulate the basilar membrane. Basilar membrane vibrates. It stimulates the organ of cortei. Organ of cortei is covered by tectorial membrane. Okay, that's it. Next, utricle saccule, also called as autolytic organ. Utricle is for horizontal linear balance and saccule is for vertical linear balance. Okay, sensory end organ is called macula. It is covered by a gelatinous layer containing calcium carbonate crystals called autoconia or autolith. If the autoconia turn free and reach any semicircular canal, it will lead to a disease called benign paroxysmal positional vertigo. It is the most common cause of peripheral vertigo, that is ear related. Causes displaced autoconia. Most commonly involved semicircular canal is posterior semicircular canal. This is lateral semicircular canal, posterior semicircular, anterior semicircular canal. The clinical feature is nothing but, guys, it's a vertigo for few seconds on changing of head position. Okay, diagnosis is mostly seen in young females. Diagnosis is Dick's Halpex manual two position. You just sit, make the patient sit and lie, and you will see nystagmus. Okay, treatment is Eppler's maneuver, also called as particle reposition maneuver, and here five position: make the sit, lie, turn head, turn body, sit. Okay, sit, lay, turn head, turn whole body, sit. That's it. Semicircular canal, guys, there are three. Lateral semicircular canal, also called as horizontal. Posterior semicircular canal, superior semicircular canal. Function is angular balance. Sensory end organ is crista. Every canal has one dilated end called ampulla. This is, can you see? Every canal has one dilated end called ampulla. Ampulla is the house of crista. Okay, and the cupula is the cover of crista. Okay, then biothermal caloric test. It is test of lateral semicircular canal. what you do, make the patient lie by 30 degree supine, and you put warm water which is of 44 degrees Celsius, okay, and cold water 30 degrees Celsius. On putting warm water, nystagmus will be seen on the same side. Remember this mnemonic, cows, okay. Warm water same side, cold water opposite side, okay. That is in a normal person. Next, eighth now, vestibulocochlear now three divisions: superior vestibular division, inferior vestibular division, cochlear division. Okay, this internal auditory canal have seventh nerve and eighth nerve. Cut section of internal auditory canal. Uh, See, cut section of internal auditory canal, guys, is superior vestibular, inferior vestibular division, cochlear division, seventh nerve. This is Bill's bar, that is vertical bony septum in the upper part of internal auditory canal. Auditory pathway mainly lines in brainstem. Remember this, E. coli ma. Eighth nerve, spiral ganglia, cochlear nucleus, auditory complex superior, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex. Auditory cortex is most lies in superior temporal gyrus of the brain. Okay. Next, guys, vestibulo-ocular reflex. When we move head towards the sound, source of sound, eyes goes towards the sound. Okay, this vestibulo-ocular reflex. Then, guys, moving into one interesting part, it is audiology. Guys, I'm still wondering how my system is able to record for this much time. Now, guys, just know this: tubercular otitis media, multiple perforation in the tympanic membrane, pale granulation in the ear, painless otorrhea, plus or minus facial palsy. Guys, audiology, simply just know, guys, see, 25 decibels is normal, okay? If 26, 27, 30, 40, 50, 60, 90 are all hearing loss. Then, guys, see, whenever the patient comes, you have to take history. See, in which year you are asking this part. I'm teaching this part. Okay, you have to take history. Like you have to ask in which year you are hearing normal and consider hearing normal or better. Okay, consider that as better year, and in which year you are not hearing, that is to be considered as poor year. Okay. So guys, here there are two ways to hear sound. One is air conduction, natural way of hearing, and it is a complete test of hearing. Bone conduction, here sound directly reaches cochlea, so it is an incomplete test of hearing. If the air conduction is poor, conductive hearing loss. If the bone conduction is poor, sensory neural hearing loss. Okay. Bone conduction is a test of eighth nerve and cochlea only. Hearing loss, there are two types. One is conductive hearing loss, and the problem is in external ear or middle ear. Sensory neural hearing loss, when the problem is in inner ear or eighth nerve. SNHL, guys, sensory neural hearing loss will be cochlear problem. Okay, next, conductive hearing loss, SNHL. Examples of conductive hearing loss, guys, what we have studied. The most common is first one, I would say, conductive hearing loss, glue ear. Sorry, um, a wax occluding the external auditory canal, conductive hearing loss. Next, glue ear, CSO, otosclerosis, which we will study. Ossicular dislocation due to trauma, wax. Okay. Sensory neural hearing loss, there are two types, guys. Okay. Sensory hearing loss, neural hearing loss. And the problem is in the cochlea, then it is called as cochlear hearing loss or sensory hearing loss. Okay. For examples, Meniere's. When the problem is in the nerve, for example, vestibular schwannoma, also called as acoustic neuroma, that is called retrocochlear hearing loss or neural hearing loss. And also SNHL example, Autotoxic drug-induced hearing loss. Okay, age-induced hearing loss, pressed bioacusis. Guys, test of audiology, there are six. Okay, for otosclerosis, special test is Galley's or Binge test. Okay, tuning for test here most commonly used tuning for is 512 hertz. Guys, in tuning fork we have three tests: Rene's, Weber's, absolute bone conduction test. Okay, it is also called a Schwabach test. Where is that? Where is that? See, guys, Rene's is nothing but what is there? Guys, Renes is nothing but it is comparison of air conduction, bone conduction. Okay, if in normal people air conduction is better than bone conduction, Renes positive. If bone conduction is better than air conduction, so it is conductive hearing loss. Renes negative. In SNHL, guys, see again, air conduction will in SNHL also will be Renes positive because bone conduction is problem. So it cannot. You guys are understanding, right? I'll come to the picture. I'll teach you here itself, okay? See, see guys, in Renes, okay, what is meant by Renes? It is comparison of bone conduction, air conduction. In normal people, air conduction is better than bone conduction. So Renes positive. In conductive hearing loss patient, you already know that air conduction will be poor. So in air conduction is poor, then Renes negative. In SNHL patient, air conduction is better than bone conduction because here bone conduction will be poor in SNHL. So Rene's positive. Weber's is nothing but keeping the the tuning fork in the center of the forehead and then asking the patient where the sound is heard. That is checking of the lateralization. The patient says it is heard in the center of forehead, then he is normal, he or she is normal. If in conductive hearing loss patient, the patient will say the sound is heard in poor ear. In sensory neural hearing loss patient, the sound is heard in better ear. Okay. So how do you know it is better ear or poor ear? Do you remember we are actually taking history from the patient itself? Okay. Absolute bone conduction test. It is a test of only the bone conduction here external auditory canal is closed, okay, with occluded external auditory canal. In normal people it is equal to, guys, here in absolute bone conduction test, here bone conduction of the patient is compared to the bone conduction of the doctor who is considered to be normal. Okay, in normal people this equal to examiner. In conductive hearing loss patient it is also equal to examiner because we don't give a shit about conductive hearing loss in absolute bone conduction because here we only check bone conduction which doesn't, that is like after the middle ear only we are checking. Okay, bone conduction only we are checking. So in even in conductive hearing loss patient the sound will be equal to examiner. Okay, but in sensory neural hearing loss patient the sound will be decreased. Points to remember, guys: Renes negative means conductive hearing loss, Weber heard in poor ear, conductive hearing loss. Bone conduction poor means SNHL. Okay, absolute bone conduction. Guys, basically external ear, middle ear, inner ear, eighth nerve. Conductive hearing loss problem, sensory neural hearing loss problem. Okay. Galley's test, it is special tuning for test used to diagnose autosclerosis. Pure tone audiometry, it is done in a soundproofed room. It is a subjective test, that is patient dependent. Okay, here we check hearing level of air conduction and bone conduction for both the ear at a different frequency, 250 to 8000 hertz. Guys, here these results are recorded in a graph called audiogram. Guys, remember, for left ear, okay, for left ear. there'll be blue color. For right ear, red color. Okay, right red, left blue. Okay, here the symbols that we use is round X. This is for air conduction. For bone conduction, always brackets things will be used. Okay. Okay, guys. PTA finding conductive hearing loss very important. Here you will see AB gap positive. See AB gap positive conductive hearing loss. Okay. Here, guys, this is sensory neural hearing loss. Did you see? Always see the number in 25 decibels. Here, guys, it is at the 40 decibels around. So, of course, below 25. So it is both also air conduction, bone conduction also below 25. So sensory neural hearing loss. There are two special dips, okay, which is two special audiograms. One is Carr-Hodgson and dip of bone conduction at 2000 hertz. This is seen in otosclerosis, okay. Dip of 4000 hertz of both air conduction and bone conduction, seen in noise-induced hearing loss, also called as acoustic dip or noise deafness. It is also called as boiler's noise. Dip of both air conduction, bone conduction. Okay, guys. Two special audiograms, guys. Presbyacusis, hearing loss due to age, Meniere's disease, due to cochlear problem. Here, apex is affected first, and here basal tone of cochlea is affected. Presbyacusis, bilateral hearing loss, and Meniere's unilateral sensory neural hearing loss. And the presbyacusis, since basal turn of cochlea is affected, here high frequency hearing loss, and Meniere's low frequency SNHL. Okay, in presbyacusis, sloping audiogram, rising audiogram is Meniere's. Okay. uh, what else, also. Next, guys, brainstem evoked response audiometry, also called as auditory brainstem response. It is done in children. It is objective test. That is why it is being done in children. Here we give sound to the ear and we record the electrical pathway from the auditory path. Uh, which mostly lies in brainstem area. Auditory cortex is present in the superior temporal gyrus. Do you guys remember? Guys, this Bera produces seven waves. Okay, Tala for a reason. Most common wave is wave 5, which is produced by lateral lemniscus. Okay, guys, this Bera is the gold standard for hearing loss. Okay, and this can also be used in medico-legal cases, in malingers, also in pediatric patients. Autoacoustic emissions, guys, sound is given to the healthy cochlea, and outer hair cells from the cochlea produces echoes, which are also called as autoacoustic emissions, which means the cochlea is working properly. Okay, best screening investigation in neonates is autoacoustic emissions, but in NICU, meningitis or high risk babies, you do bear a stapedial reflex, guys, on hearing loud sound. Okay, this eighth nerve is efferent and the seventh nerve here is afferent. On hearing loud sound, this eighth nerve sends us the loud sound, which is afferent message, and makes the seventh nerve has the efferent messenger to pull out the stapes out of the old window. Okay, so that all the full sound is not transmitted to the cochlea, so cochlea is saved from any further damage. This reflected in absent in deaf patient. Eighth nerve is gone, Bell's palsy patient, seventh nerve is gone, then autosclerosis patient, which is stapes problem. Tympanometry, also called as impedance audiometry, also called as tympanogram. Here we check movement of freedom of ossicles in tympanic membrane. It shows five type of curve. A type A normal people, type B seen in glue ear. It is flat curve. Type C seen in eustachian tube dysfunction, and in retracted tympanic membrane. Okay. Type AS, it is seen in autosclerosis. Type AD is seen in osteocular dislocation. Yeah, this conductive hearing loss, guys. Wax causes 30 decibels, glue ear causes 10 to 40 decibels, ossicular dislocation with a normal tympanic membrane 54 decibels, with perforation 38 decibels. Because, guys, if the tympanic membrane is normal and the ossicular is dislocated, guys, since it is intact, like what to say, guys, if there is a problem here and it is intact, there'll be more conductive hearing loss. But if there is perforation, guys, sound will directly enter, and that will causes less hearing loss. Do you get it? So intact tympanic membrane 54 decibels with the perforation 38 decibels. Permission noise level 85 decibels, 8 hours a day, 5 days a week. Drug induced hearing loss, so don't give to the patient with itself. Aminoglycosides, CANs. Kanamycin, amikamycin, neomycin, gentamicin, streptomycin, loop diuretics, furosemide, ethacrenic acid, anti-malarials, quinine, chloroquine, which is quinine, guys, Quin, quinine, NSAIDs, aspirin, ibuprofen, indomethacin, anti-cancer cisplatin, carboplatin, miscellaneous is desferoxamine, erythromycin, vancomycin. This is used in thalassemia patients for iron overload correction, guys. These drugs cause high frequencies SNHL. So here, high frequency audiometry is used to diagnose ototoxicity. A facial nerve, it comes from pons through temporal bone, it enters the ear through internal auditory canal. Next comes out through stylomastoid foramen, passes through facial nerve canal, also called as fallopian canal. It has got three segment, guys. Just put it in your head. A lab time must. Okay, labyrinthine segment, narrow segment, tympanic segment, horizontal segment, mastoid segment, vertical segment. This labyrinthine segment is also called as bottleneck of facial nerve. Okay, bottleneck of facial nerve. This image is very important, guys. This is internal auditory canal, stylomastoid foramen. Okay, this is first genu. This is second genu. From the first genu comes a nerve called superficial petrosal, greater superficial petrosal nerve. In the first genu, there is presence of geniculate ganglion of facial nerve. Okay, geniculate ganglion. Do you remember, guys, in modulus of the cochlea we have spiral ganglion of eighth nerve. Then, guys, from second genu comes nerve to stapedius, and mastoid segments comes to chordate tympani. This greater superficial petrosal nerve comes from first genu, supplies the lacrimal gland, tear gland. Test is Kimmer's test to know how the nerve works. Okay, is the nerve working good or not? Nerve to stapedius, it comes from second genu, that gives stapedial reflex. Test for this nerve is stapedial reflex. Chordate tympani, it is arises from mastoid segment, also called a vertical segment. This gives taste sensation to the anterior two-third of the tongue. Okay, anterior two-third of the tongue. Forgive me, guys. I have this cold. I have to go eat. What is the time? It is. Please collect the award from. Guys, what else? Then, guys, test the three test for three branches help us to find out site of energy. Okay, site of energy. Sorry, site of injury. Okay, See guys, up to the level, see, if you just know this, then you will understand this point. Just put these things in your mind, okay? Facial nerve disorders, first is Bell's palsy, it is most common lower motor neuron facial palsy. Guys, lower motor neuron facial palsy, keep in your mind that the frontalis muscle, that is forehead muscle, is also paralyzed. Here, guys, one complete half of face is paralyzed. Inability to close the eyes on affected side, that is looping, drooping eyelids on the affected side, that is called ptosis. Okay, it is idiopathic, sudden onset lower motor neuron failure palsy, mostly unilateral, because there is edema on the labyrinthine segment, which is the narrow segment caused by, it is not proved it, but maybe HSV1 virus. Angle of mouth is deviated to the opposite side, which is the normal side. Okay, contralateral side. Next, eye closure in normal side, forehead muscles are also paralyzed cause it is lower motor neuron palsy, but in upper motor neuron facial palsy, the forehead muscles are spared. It is not paralyzed. Okay, patient complains of hyperacusis. What is this, guys? This is due to loss of stapedial reflex. Why? It is reduced tolerance to sound. Can you hear this sound? For people with facial palsy, they can't even hear this sound. They'll feel, oh my god, like that, Next, absence of nasolabial fold on the ipsilateral side. Okay, drug of choice is one steroid for edema. Okay, this is for 3 weeks. Guys, what they give? Prednisone, acyclovir, because we suspect HSV1 infection. Antiviral if the patient comes within 3 days. Okay, guys, artificial tear drops because to prevent exposure keratitis, corneal damage. Do you actually understand this? And if you have studied this part, you will understand the following part very easily. Okay, then physiotherapy. Why physiotherapy, guys? Because of Bell's palsy, you have to get your facial recovery, right? So for that, we are doing physiotherapy and facial recovery. Here it is seen in 85% of the cases. Guys, just know iatrogenic. Iatrogenic means is just by the doctor. Okay, injury to the facial nerve most commonly by parotid during parotid gland surgery. Second most commonly during mastoid surgery. Okay. Next, guys, Ramsay-Hunt syndrome, also called as herpes zoster oticus. It is caused by a reactivation of varicella zoster present in the geniculate ganglion of facial nerve in the first genu. Okay, first genu of facial nerve. Guys, do you remember this guy Ramsay? This is a very very bad guy, guys. So that is for facial recovery only seen in 50% of the cases. Here you will see painful vesicles on the external ear. Okay, and also you can see lower motor neuron facial palsy. Here, guys, treatment is for because of this virus you are giving acyclovir and and we are giving steroids. Okay, facial recovery only seen in 50% of the cases. Merkel's Rosenthal syndrome, guys, swelling of lips, wishard tongue, recurrent facial palsy. Just know this, okay? Head injury, guys, it will lead to fracture. What bone fracture? Temporal bone fracture in case. Specifically, in here we are studying about temporal bone fracture. It doesn't mean head injury will only cause temporal bone fracture. Okay. Here, guys, in temporal bone fracture, you will see EK motion, that is blue color discoloration or master, that is called uh, battle sign. Okay. And here CSF autoria can also be seen. CSF autoria is it through here CSF will leak. Okay. Next, temporal bone fracture can lead to facial paralysis. Okay, this can be this middle cranial fossa. Of course, everybody knows. Please refer to this picture. Okay, just making it fast. There are two onset, guys. Basically, guys, after fracture, facial paralysis will be in two ways. One is immediately, one is delayed. Okay, if the facial paralysis immediate, then it means, guys, see, this is the fracture line. If the facial paralysis immediate, that means the nerve is actually injured, properly directly cut or injured by the fracture line. Okay, not say cut, but um, like you can understand, right? Always mm, think about this picture. If the fracture line is just like intersecting, then immediate effect, immediate paralysis, immediate surgery. Okay, but when the nerve or this fracture line is parallel to the nerve, then for sometimes it will, after some time there'll be edema, right? And because of the edema there'll be delayed onset. Okay, for delayed onset, what you do, you give steroids. Okay, oral steroids. Okay. Next. Guys, next, superior semicircular canal dehiscence syndrome. Here, guys, it is nothing but superior semicircular canal is disrupted a little bit, causes congenital or traumatic head injury, guys. Here you will see Thulius phenomena, autophony, vertigo and blowing of nose. Thulia phenomena means vertigo on hearing loud sound, autophony, which is also seen in Pachula East Asian. We have already studied, that is hearing our own voices, vertigo and blowing of nose. Guys, here the cochlea is normal, so no SNHL. Here sound leaks from the superior semicircular canal dehiscence. This is called third window phenomena. Investigation is HRCT temporal bone and also pure tone audiometry. Treatment is surgical closure of the dehiscence, guys. Autosclerosis, very important, guys. The early stage of autosclerosis is autospongiosis. Here, do you see this, guys? This is the earliest stage. Okay, this is the earliest stage. Everything will be pink, guys. Why? See, this is pink. No, earliest stage, everything will be pink, guys. Okay. So it is nothing but fixation of uh, foot plate of stapes, so that the movement of the piston is restricted, guys. It is more common in females, young females 2 to 30, guys. That is 20 to 30, between that years. Okay, it is a genetic disease, autosomal dominant. Very surprising. It is bilateral, guys. Here there won't be fast. It is a gradually progressive disease. But if you get pregnant, guys, then it will aggravate it. The disease focused most commonly on the original disease focus in the sense where it starts from. It is from the fistula antifenestrum anterior to all window of cochlea, and then it gradually surrounds the flute plate from all around. Okay, color of the focus of disease is, I have already told you, everything will be pink at the start. Okay, and then it gradually turns white. Clinical feature, young female with bilateral hearing loss, guys. People will say, "Sir, I can hear slowly, like gradually progressive conductive hearing loss." Okay, this patient will have will hears better in noisy areas. That is called paracusis villi. On examination, guys, 90% patient will show normal tympanic membrane. Nothing will happen. Nothing will be seen. But the 10% patient will show SWOT sign positive. That is flamingo pins appearance. Okay. This is spots and flamingo pink appearance. It is seen in early stage. Okay. PTA, pupil audiometry shows dip at 2000 Hz, also called as Carhart source. Tympanometry shows type AS curve. Okay. Treatment of choices, surgery. Stepidotomy is better than stepidectomy. So before that, first step is we do tympanotomy. Okay, in the surgery, we replace the fixed stapes with the artificial stapes, piston prosthesis. Other treatment, guys, hearing aid if the patient is unwilling for surgery. Sodium fluoride, it is the treatment of choice for only SWOT sign positive patients. Okay, what it does is it slows the progression of the disease. Okay, Wander-Harvey syndrome, guys, it is a collagen disorder, just imagine blue. Okay, which means blue sclera, autogenesis imperfecta, autosclerosis. Okay, next, vestibular schwannoma, also called as acoustic neuroma. Here, facial palsy is rare, guys. It is slow growing benign tumor of eighth nerve. Most common site of origin is inferior vestibular division. It is a brain tumor of eighth nerve. It is most common type of cerebellopontine angle tumor, guys. It is most common type of cerebellopontine angle tumor. Remember that, guys. This is cerebellopontine angle. Okay. This is cerebellopontine angle. Okay. So it is most common type of cerebellopontine angle tumor. It is mostly unilateral, except in neurofibroma type 2, which is bilateral, guys. Clinical features, guys, put this up. UT, a unilateral gradually progressive hearing loss, tinnitus, imbalance. Okay, guys, here cranial nerve involvement is in uh, this sequence 857. Eighth nerve causes UTA, fifth nerve causes absent corneal reflex, guys. when you touch with the bud, it is the earliest sign. Okay, when you touch with the bud, you won't close your eyes. Okay, next is seventh nerve. Sensory division leads to loss of sensation in the posterior superior part of external auditory canal. This is called Hitzelberg sign. Do you guys remember we studied sensory supply of external auditory canal? AT, posterior superior part is supplied by this sensory division of facial nerve. Know that? Do you guys remember that? Okay. Yeah. So guys, investigation best is radiological investigation. Best radiological investigation is gadolinium enhanced MRI on ear examination, normal otoscopy. Okay, normal otoscopy, guys, because this is a problem in the brain, not in the ear. Okay, guys, glomus jugular. Glomus is a type of tumor. It is benign. It is non-encapsulated, so it is locally invasive, highly vascular tumor full of blood vessels. Okay, it is mostly seen in females. Site of origin is glomus cells lying around is a jugular bulb. Here, guys, tumor erodes the floor of hypotympanum, gets into floor of medullary, gets into hypotympanum. Okay, guys, and also this picture is very important. This is bilateral vestibular schwannoma. This is vestibular schwannoma unilateral, guys. Bone looks black on MRI. Just know that point also. Guys, here rising sunshine, okay, which is the tumor erodes the floor of medullary and gets into hypotympanum. Then tumor grows into the external auditory canal, has a red bleeding mass. This red bleeding mass blanches on ciliation, that is, it becomes pale, okay, on ciliation. This is called brown sign. CT scan will show self sign. Investigation CCT angiography and the biopsy is contraindicated. What are the features? It is highly vasculated, so obviously pulsatile tinnitus will be there. Next, a bleeding in external auditory canal. Of course, it is a red bleeding mass. Then conductive hearing loss as usual. Treatment is surgery, guys. Okay. Mean it is also called as endolymphatic hydrops. What is the problem? It is also called as glaucoma of the ear. What is the problem? Due to high endolymphatic pressure, the in the inner ear, due to poor absorption of endolym by endolymphatic sac. We have already studied it. What is endolymph? It is produced by stria vascularis of cochlea, and the endolymph is absorbed by endolymphatic sac. Guys, it is a unilateral disease and it is episodic disease just like migraine. It is usually seen in third to fourth decades. Okay, third to fourth decades, which means between 30 to 40 years old. Okay, triad, guys, tinnitus first sign in the morning, then vertigo, then hearing loss. Okay, waking up with tinnitus, vertigo, and then hearing loss. Other than that, sweating will be there, fullness in the ear will be there, and very interestingly, diarrhea will be there. Okay, if the episodes will last for few hours but finishes within 24 hours, guys. Some patients falls during the episode itself without turning unconscious, which is called Tumarkin crisis. Okay, in between episodes, guys, these things happen during the episode, and in between episode, what will happen? DTR will happen, which is the Diplocusis. Patient hear the same sound in two different frequencies. Next, Tullio's phenomena, which is nothing but patient gets vertigo on hearing loud sound. Next, R is recurrent phenomena. Here, loud sound is heard more loud, and also patient uh, hates noisy areas. Let me put it that way. Patient hates noisy areas. Okay. Have you ever heard of this guy Sam Gardner from this Netflix series? I forgot. I forgot the name of it, but it is a very good series. Sam Connor, like this guy. Next guy says the few years later, cochlear damage starts due to high endolymphatic pressure. Guys, now the problem is there will be fluctuating hearing loss. Fluctuating hearing loss in the sense, guys, sometimes it will be good, sometimes it will be bad. That is the fluctuating hearing loss. Okay, in mean years, It is unilateral, so one cochlea is affected. Understood. Apex is affected, guys. Specifically, apex is affected. So low frequency sensory neural SNHL in mean years. Okay. Investigation is, guys, electrocochleography. PTA showing rising audiogram. Okay, we have already seen that. Medical treatment, guys. Treatment is medical management. Okay, if it is medical management, during the episode you give anti-vertigo, in between episode you give acetazolam, a diuretic. Okay, but if the medical management is not it is not useful. Okay, you have recurrent vertigos and all that, so you go for surgery, endolymphatic sac decompression surgery. For endolymphatic sac finding, landmark is Donald's line. Okay, and other option is transtympanic injection of gentamicin. It is autotoxic drug, it will kill the ear, guys. This is called chemical ablation or chemical labyrinthectomy. Okay. Next, mania disease, it reduces vertigo by, so you will feel better. Okay, it is nothing but intermittent low pressure pulse therapy for inner ear. Uh, we completed the year almost, guys. Ear implants and devices. Before that, know something that 26 to 40. Know this value, guys. 26 to 40, no, 20 up to 25 normal. Okay, 26 to 40 mild, 41 to 55 moderate, 56 to 70 moderately severe, next 71 to 90 severe, more than 90 profound. Okay, so till this moderately till the severe. Okay, till severe you can use hearing aid, but for profound you can only use cochlear implant. What is hearing aid, guys? It is it is preferred in conductive deafness. Okay, it is just a sound amplifier, guys. It has nothing much, but it is a sound amplifier. It is not a big device. Okay, big devices for who have big devices in the sense, not much of interference is needed compared to other. That's what I was about to say. Okay, it is not much use in profound hearing loss, so we do cochlear implant surgery. Cochlear implant surgery, guys, what is the indication is bilateral profound SNHL, guys. If the both ear are totally fucking gone, you cannot hear anything, then you do cochlear implant, guys. Okay, when hearing aid becomes useless, of course. Here, guys, cochlear implant, what it does is stimulate the eighth nerve electrically. So prerequisite of the surgery is normal eighth nerve on MRI. Okay, if the eighth nerve is normal only, you can do cochlear implant. Okay, age of surgery in a deaf child since birth, that is prelingual deaf child, that is from birth itself the child is deaf, age is 1 year and above. Okay, and after doing surgery you have to give speech therapy for the child because the child did not hear anything properly. Okay, so you get it right. Yeah, two components of cochlear implant: external component outside of the body, internal component it is put inside. Okay, external component just have this mnemonic, guys: master blaster Sachin Tendulkar, microphone, battery, sound processor, transmitter. Okay, microphone, battery, sound processor, transmitter. Next internal component is electrode, which is placed in the round window, placed in the scala tympani of the cochlea through round window. Okay, guys, auditory brainstem implant indication is neurofibroma type 2, which means both the eight nerves gone. So you hear nerves are gone, so obviously cochlear implant cannot be useful. So you do brainstem implant. Okay, and here AB electrode is placed in lateral recess of fourth ventricle. Okay, next it is fourth ventricle. Oh, next, guys, bone anchored hearing aid. Here, just know something is what are the indications. Bone anchored hearing aid, since it is bone anchored, it stimulates the cochlea directly through bone conduction. Okay, indications is, what are the indications? What is this condition is called, guys? This condition is called absence of pinna, anosia. Then external auditory canal atresia, stenosis, or chronic discharge. in ear as it is wet. If chronic discharge is happening, you cannot put any other device because the device will get damaged. So these are the four indications here that you must know is titanium screw, abutment, sound processors. Okay, this is titanium screw, guys. The part which com which, which combines the titanium screw is this sound processor is abutment. Just know this, you will be all right. What else to know? Guys, glomus tympanicum. We have studied glomus jugular, right? The same kind of tumor, but arising from the promontory. Promontory is nothing but projection of basal tone of cochlea. Okay, guys. Next, simple thing. Okay, outer air cell, inner air cell, three layer, single layer, cylindrical flask, max in number, minimum in number, efferent, afferent. They generate action potential in modulate function of inner hair cell. What else should we cover in here? That's it, guys. We have completed here, and here is actually kind of boring to be honest, guys. But this thing, this nose, throat, and all very short diseases. We'll have a lot of condition, but they are all short. Very easily understandable short conditions only. Here is like too much. What to say, guys? Here is like. Mm, lengthy, if I have to, not lengthy, I would say, but it is like irritating at least for me. So, guys, let's start with nose. Yeah.